and the implant was functioning so good without any periodontal bone loss, without any gingival inflammations, any recession. So good it was. So complications are common with implantology. Once if you plan it and once if you could execute it in a right manner with adapting to all the recent protocols of implantology, we can come to a very less amount of complications, and every one of us can go ahead with putting an implant. Out of the complications, Madam was beautifully explaining the basics of peri-implantitis. And this peri-implantitis is one of the most common problem what implantologists can come across in day-to-day practice. I also have given 2-3 lectures about smoking and implants in IDA head office. So implantitis is peri-implantitis is one of the common problems we come across, and most of it is can be easily manageable. We can't say that, as Madam said we should not immediately then it's going to be a failing implant. We can't come to a conclusion it's a failing implant. We did a full arch maxillary arch reconstruction with bicortical screws. I don't know how many of you use bicortical screws implant. One of my student and good friend Dr. Alavel Rajan, he comes to my clinic to put bicortical implants. And we did, he was a heavy smoker, the patient was a heavy smoker. I told him about the risk of implant and smoking, and we got the consent and all done, and then we placed about 11 implants or 11 implants or 8 implants in the upper maxilla. And the canine and the premolar region, we had a persisting inflammation. So we thought it was going to anyway fail, because you know that bicortical screw, they just weld everything and they splint everything. They splint implants. If like what we do for if there is a mobile implant or a mobile tooth, we splint the tooth to the surrounding. If there is a mobile implant, they splint the implant also to the surrounding implant. They weld the implant. While putting itself, they do the welding and things like that. So we have a lot of advances. And a lot of, I think Madam has missed about probiotics. Other non-surgical methods of, they have chewing gum like thing to minimize this peri-implantitis. You have a probiotic chewing gums or lozenges. It's like, cough syrups and then you can have these tablets onto the, when you are using an implant. So this releases the probiotic and releases the inflammation all around the implant. So if you suspect some amount of mild inflammation, I think Madam will also explain more about this probiotic as taking it as a question from me. Okay. So the role of probiotic. There are certain markers available. Nowadays, we take saliva, send it for biochemical investigation. We identify some markers to identify what type of peri-implantitis can be possible with this patient. Well, how many of you can judge whether the partial edentulous patient having an implant will have more of implantitis, or a full mouth rehabilitated patient will have more of implantitis? Anybody? Why do you think so? Yes, so you have a contaminated tooth by the side of it. So anybody who is going to do a partial edentulous implant, like single implant, 2 implants, posterior implants, you are going to have implantitis initially after putting implant or after loading. Anybody? After loading or before loading? Yes, usually you get an implantitis only after loading, because all that is the force what is given to the implant which counts. Thus that you have heard about many surfaces of implant. How many of you know about surfaces? Stylomax. How many of you use noble backer? Noble backer surface it is a trademark. They don't reveal what is the surface. Biologically fit. Surface. Tie unite surface. Sand blasted surface. Endopore surface. How many of you use life care endopore? Endopore implants. Tappable implants. These are surface coated. Whatever make the implant is made up of, whether it is titanium, the surface should be very competent enough to have that osseointegration. So what they started doing is they started treating the surface with sandblast, with hydroxyapatite coated. To putting a dentium implants, they are hydroxyapatite coated. What is the role of hydroxyapatite in this implant? Is to get the osseointegration, to get the bone attracted. So, is there any difference between these surfaces on the implant? These are the things what we need to know about. There are about 22 surface treated implants. The implant in the implant in a tie unite implant. The evidence based literature says this tie unite implant has got a 120 years to 80 years of survival. A noble good implant. We are taking that implant. Same sand blasted implant. If we are not tapping any of the implants, do you use any tappable implants? They still do tappable implants as a patient-specific implant. We don't thread the implant, we tap the implant. However, a cylindrical implant with endopore surface. Endopore is a surface which has got a lot of pores into it, so that the osteoblastic activities will be more. They have a center opening in an implant. Why do you have a center opening in the implant? They need an bone conduction from this side to this side. They said that holds the implant for a longer time. We need to analyze which of these implants has got more of peri-implantitis. We should avoid those implants. There are literature which says that these surface implants have got more reaction. Why this implantitis come? It is because of an inflammation. So as soon as you put that surface, the surface should be very competent enough to stay in that bone. If you are not giving a correct surface implant in that area, it induces some amount of inflammation. That is the reason why some implant fails immediately on that. It should be custom made. All implant, whatever implant kit which our implant practice, it is going to be a failure today. It is not that a single implant system can be practiced. It should be with a multi-implant system. Or a multi-technical technique should be used on an implant. So one side the state abutment podla, another side the multi-unit abutment podla, another side it can be an active implant, thread implant one. So you need to go in that aspect. Hi, welcome. Come here. Please come here. Come here. She has just finished the talk on a peri-implantitis, so I am just moderating it. Okay? Fine, welcome. So that is the status. So we need to know when we start doing it. All of you are doing an implant here. All of you are doing. Your consultants are doing, or you are doing. Your consultants are doing. Right? Good. So that is the reason why most of us will not be knowing about what is the content of implant. We are not interested to purchase the implant. Know about surface of the implant plays a very major role in such type of peri-implantitis. And loading the implant, molar, load, force, all that counts in the implant. You will put a very good implant, 3 months it will be strong, stable, no problem. You put a transmucosal screw or gingival former, it will be very good at that time. After loading the implant, 3 weeks you start slight redness in that area. It will start moving, because of, why? Because we are not calculated the occlusal force to that implant. So that is the reason why the basic concept of doing an implant, like 2 millimeters on either side, 5 millimeters on either, between the anatomical structure and all this counts in implant. Yesterday, one of my junior doctor, he is a good friend of mine, he is a professor in oral surgery, he came with an X-ray. One implant was pushed into the bone and it was lying in the neurovascular canal. One short implant made recently, yesterday only they retrieved the implant in Pondicherry. I wanted to bring it to the notice, how can an implant go into the bone? The implant can go into the sinus, okay? The implant can go into the pterygoid space. The implant can go into the nose. How can an implant can go into the bone? Medullary bone. Medullary bone, adana nama drill padrom. And the bone kulle eppadi implant slip agum? No, it can't. 6 mm, 8 mm, 9 mm, 12 mm, you are going to drill depth na, that depth kulla da irukku, adukku kizhe eppadi poga mudiyum? Adukku kizhe eppadi implant povum? It should be a pathological bone. Okay, what pathological bone? It should be a cyst theriyama cyst kulla padala. So appalla kandupidichalam, purukku CBC illa we can do. This patient was taking a methotrexate and some bone dissolving drugs. Okay, and the Mari product the patient has started putting 2 implants. And one implant went into the medullary bone. There was no particle D1, D2, D3, D4. That is very important nowadays. We need to do that. If you have a more of soft bone, medullary bone, the implant, we can't thread the implant into the medullary bone. You need to get a cortical purchase of the Nowadays, even in conventional implantology, they say more of one cortex you need to take a purchase of, or else the implant is not going to be successful. That is why bicortical screws are little more attractive, because it gets a purchase of the cortical bone, thick bone. So in conventional implantology also, if you have a good purchase of cortical bone, though you depend on the medullary bone, the peri-implantitis, the force distributed to the bone, tooth and the implant, all this should be calculated. The prosthetic related issues plays a very major role in peri-implantitis. Oral hygiene plays a very important role. Surface of the implant plays a very important role. The position, depth position of the implant plays a very important role. The lingual tilting and the labial tilting plays a very important role in the implantitis. Everything plays a role in implantitis, not only the pre-existing periodontal condition or your smoking. Okay, so that is the thing what I wanted to share. We have a very beautiful scope after these AYSWARYA, and many people are coming here to teach implantology. In those days itself, without any learning curve, we did a lot of cases, and we have a lot of successful implants staying in the mouth. And today we have 100% success rate, provided we do it rightly with the right knowledge and get the adequate updating this very, very important. Don't take it as anything, you just see it clinically. Don't go by the textbooks. If textbook picture shows you that this is how you need to do a scaling, we can't do that on a patient. It's very difficult. We need to see that what mentor doing that. Only then we can do it. It's very difficult. Or else you need to go through a learning curve of 10 cases of failure to say that this is what is happening. You can't take it from textbook nowadays. It is only by a mentor who can teach you. So implantology is so. It's very, very important you learn implantology from a mentor and who has experienced it. The tactile sensation of the bone while drilling is very important. How many of you felt the bone when you are operating? How many of you have felt the bone when you are operating a third molar? யார் டிஃபரன்ஸ் கண்டுபிடிக்க முடியும்? போனை கட் பண்ணும்போதே third molar டிஃபரன்ஸ் யார் கண்டுபிடிக்க முடியும்? Yes, there lies the problem. Whether it's going to go for a dry socket, whether it is going to heal better, whether it's going, so that tactile says, no, the bone is not good. The experienced hands will say that the bone is not good. The bone is good. The bone, this needs little tricky affairs. When you use lot of bone substitutes and bone GTR, GBR membranes, will it be inflammation is more or less? It is going to provide more of peri-implantitis or less. All these are debatable topics. So unnecessarily, don't pack the area with bone graft. Don't pack the area with GTR membrane. All that is going to be a little complicated. Whenever necessary, we are going to do it. So thank you for giving me this opportunity to moderate this session. It was a fantastic talk by Madam. Best wishes to you, Madam. And I give the mic to the...
Thank you very much.